All right, welcome everyone. This is Smilow Shares Breast Cancer Awareness Month. This is the first of 3 presentations, and this one is called Understanding Breast Health, Screening, Genetics, and Prevention. And I'm John Lewin. I'm the moderator for this session, and we have 3 experts. So we have Dr. Parisa Lotfi, who's my colleague in the Department of Radiology and Biomedical Imaging, and she will be talking about screening. And Tracy Battaglia, who is Professor of Medicine and Associate Director, Community Outreach and Engagement for the Yale Cancer Center. And Melinda Irwin, who's Associate Dean of Research and the Susan Dwight Bliss Professor of Epidemiology, Deputy Director of the Yale Cancer Center, who will be talking about risk modification. And so without any further ado, I will stop sharing my screen and Dr. Lotfi can start her presentation.
Okay. I hope everyone is having a good evening. I'm going to briefly talk about breast cancer current screening recommendations. We all are aware or have heard of the U.S. Preventative Services Task Force. This is a task force that is assigned by the government to look at medical data and make recommendations for screening different types of diseases. But specific to breast cancer screening, they just modified their recommendation recently last year, and they lowered the start age for screening. Now they recommend women aged 40 to 74 get screened. However, their recommendation says every 2 years. And women 75 years or older, they said that there isn't sufficient evidence to assess the balance of benefits and harms of screening mammography in this population. They also recommended that women with dense breast, that there isn't enough evidence to assess the balance of benefits and harms. Now, we can talk about an hour about the data they looked at and what they considered harms and benefits. But one thing they considered a harm of screening was anxiety of women and potential callback rates. Briefly, I just want to say that when screening mammography is the standard of care, and this is going back decades, and we have extensive research proving that screening mammography saves lives. Women who had a screening mammogram compared to women who didn't definitely live longer, and that's how we know. Everything else, ultrasound and MRI and other modalities that I will talk about, like contrast enhanced mammography, we don't have enough data to know, decades worth of data to know if these are actually making women die less of breast cancer. So current guidelines, this is a table that is talking about the different societies, medical societies, talking about screening guidelines. I talked about the task force. It says start at 40 every 2 years. And then different societies like ACOG is the OB/GYN Society, American Cancer Society, American Medical Association. They all pretty much are recommending starting at 40, and for the most part, annual screening is recommended. For women older than 75, it's based on shared decision-making. If people are in good health, if women are in good health and they have at least 10 more life years ahead of them, it's a good idea to continue with mammography, but that's a personal choice and it can be discussed with their primary care physicians and come to a decision that's appropriate for that individual. I am a radiologist, so I'm going to talk about American College of Radiology and Society of Breast Imaging recommendations, which basically says start at 40, every year get a mammogram, and there is no age limit. But obviously, we do consider individual health status. So, American College of Radiology recently, in the last few years, changed their recommendations in terms of breast care. And they brought to light the importance of having a risk assessment for women. And they're recommending that women get a risk assessment by age 25. Every woman should know if they're high risk, low risk, if they're average risk, discuss as far as they know. Discuss that with their primary care or their gynecologist so that they can appropriately be screened starting at that age. So high-risk women, as determined by the risk assessment models or deemed high risk, if they desire anything more than a mammogram, because they're high risk, they should get some other supplemental screening. So MRI has been our traditional screening tool for those women. If for some reason they can't undergo MRI screening, and there could be the different reasons for that, definitely ultrasound, and at institutions that have contrast enhanced mammography, they should undergo that procedure. I will talk a little bit more about that in a bit. Women who have dense breast and are not necessarily high risk, but they want supplemental screening, they can get a breast MRI. However, sometimes insurances don't cover that. Most insurances don't, or they're cost prohibitive, or there's a contraindication for getting an MRI. It's important that these women know they have options. Ultrasound or contrast enhanced mammography should be considered. If someone is intermediate risk, and again, these are calculated lifetime risks, with which my colleagues will talk about in a minute, and have dense breast, of course, they should continue with mammography, but also get MRI or ultrasound. So just to talk about mammographic density, mammograms are black and white and gray, and basically anything that's gray or black is good. This is the opposite of real life, and white is glandular breast tissue. However, cancer, cysts, benign masses, anything else that is not fat will also be white. So when we are going from left to right, we are seeing an increase in the breast tissue density. This on the right side is considered an extremely dense mammogram, and you can see that the majority of this breast is white. And if this breast had a small cancer in it, it would be very difficult to see it because it's going to blend in with the adjacent breast tissue. And this is why it's important that women who have extremely dense breasts should consider additional supplemental screening. This is a fatty breast, and you can see that if there was a mass, this is a normal structure here, but let's say there was a mass, it would be white and it would be extremely easy to appreciate it. Of the 4 categories, half are dense and half are not dense. And about half the population has dense breast and half the population doesn't. The last one, the extremely dense category, is about 10% of women. So not very common, but extremely important. Density by itself is also a risk factor. So women who have denser breast have a higher risk for developing breast cancer compared to women who have a fatty breast. For example, 1 and 4. The 4, which is extremely dense breast, has a 4 times more risk of developing breast cancer compared to a fatty breast, and about 2 times higher than an average breast. So when we have increased density from, again, left to right, we can see the density of the breast, or the whiteness is increasing. That lowers our sensitivity of mammography and increases the risk of cancer not being detected. I don't like using the word missing cancer. We're not missing it. We're just not seeing it. We're not detecting it. So as we go from left to right, you can see that the risk increases for non-detection of breast cancer. And the extremely dense breast has a more than 60% risk of non-detection. So in order to look at dense breast and utility of additional supplemental screening, there were several trials that were recently published. One was the DENSE trial, which is the dense tissue and early breast neoplasm screening. This was a very good trial. It was a randomized controlled trial. It was in the Netherlands. And they added MRI in a population of 50 to 75-year-olds, women who had extremely dense breast tissue and had a normal mammogram. And they wanted to see different things, but one was they wanted to see patients who had that added MRI, did they have a lower rate of interval cancer? Interval cancers are cancers that develop in between screening timelines. And for them, it was every 2 years. They also looked at other things. For example, they wanted to see what is the detection rate of MRI? Are there false positives? What kind of tumors are detected by MR? And some other characteristics. They were lucky. They looked at 40,000 women, and about 8,000 of them had the supplemental MRI. And what they saw that the rate of interval cancer was about half in women who had MRI compared to mammogram only. So it was 2.5 per thousand compared to 5. And basically, this was great news. I should also make a note that these are average risk patients, not high risk patients. And the women who had the MRI, they had about over 16 per thousand rate of cancer detection, which is great. Again, mammography alone finds, if you have tomosynthesis, on average 4 or 5 cancers per thousand. Another trial called BRAID, breast screening, risk adaptive imaging for density, wanted to see, in addition to mammography, other supplemental screening imaging tools effect. For example, ultrasound, contrast-enhanced mammography, and MRI in detection of breast cancer. They had about 9,000 patients, 6,000 completed those extra modalities. And the cancer detection rates were really great for abbreviated MRI is just the shorter version, shorter time version of contrast-enhanced MRI. And in that population, they had about 17 per thousand detected cancers. Contrast-enhanced mammography was even higher, 19-ish, and ultrasound was only about 4.2 per thousand. You can see that. And in that population, the cancer detection rate was 8.4 per thousand. So you can actually look at the numbers and appreciate that ultrasound was just slightly better, but MRI and contrast-enhanced mammogram more than doubled it. Tumor size was also much smaller. On the average, it was about 1 centimeter in women who had the MRI and contrast-enhanced mammogram. And ultrasound detected tumors were slightly larger, about double the size, 22 millimeters. These are averages. So you can see that earlier detection is key with contrast-enhanced modalities. Now, just to say a little bit about contrast-enhanced mammography, the premise is that tiny little tumors, anything more than 2 millimeters, will demonstrate angiogenesis, and that means that they're going to grow new blood vessels. These blood vessels are leaky, and when we inject a contrast material through an intravenous access, they go to the breast and they accumulate in these tumors. We can detect them with two ways. One is contrast-enhanced mammography, and one is MR. A lot of people, patients, physicians know about MRI. I won't go into detail about that, but contrast-enhanced mammogram is essentially a mammogram that is obtained before and after administration of contrast. And this is an example of that. When patients undergo contrast-enhanced mammography, they get a normal mammogram, which is this image here. And this is another view of the same. It's labeled left CC and left MLO. And then another image, mammogram image, is obtained. Those images are subtracted, and what remains is anything that picks up the dye. So in these two images, you can see that there is a tiny little mass that shows up in the left breast, And it's completely obscured. You don't see anything like that because this is an extremely dense mammogram. And so contrast enhanced mammography is a mammogram that is really not affected by breast density. So let me just, oops, I lost my share. All right. What we don't have answered, there are several questions with in general and what these trials that I mentioned have not answered. We know that mammography saves lives by decreasing mortality from breast cancer. We don't know that about MRI or contrast enhanced mammography. So there's a lot of research being done about that. Hopefully we'll have that answer at some point. We also don't know how feasible it is to have these other supplemental tests in terms of logistics, cost, capacity for women who are not at high risk. As you know, demand for imaging is very high. We have very low MRI capacities, and contrast enhanced mammography is not available at every institution. At Yale, we are increasing our MRI capacity at different sites. However, we are sharing with other body parts. You know, everybody wants to have an MR. It's a highly utilized test. And we don't have enough slots to do diagnostic MRs, to do high-risk screening, and also average screening of the women who have dense breasts. We will be starting a contrast enhanced mammography program in the next 6 months or so. We'll be doing it at both two campuses at Smilow and at our North Haven campus. And that'll be great. It'll be very, very exciting for us to start that program and offer women additional supplemental screening. All right.
All right, very nice. Dr. Battaglia?
I'll pull up my slides. Good evening, everyone. I see there's a couple questions in the chat, John. I don't know if you want to take one or two while I'm...
If you would like, we definitely will have time at the very end for everybody's question. Well, pretty much. So one of our attendees asked Dr. Lotfi about invasive lobular cancer. How would that show up on a contrast enhanced mammogram?
So similar to MRI, it will show up because lobular cancer also has neovascularity. As you know, lobular cancer is not a very common cancer. It's about 10% of our cancers. And occasionally it may not enhance, it may not take up the dye, similar to MRI. And that's why screening mammography, the actual mammogram portion of it is super helpful. We read those studies together and not ignore one or the other finding. So if we know someone has lobular cancer based on a previous biopsy or diagnosis or whatever, we can either do contrast enhanced mammography or MRI for extent of disease and other diagnostic workup.
All right, very good. Let's move on to the next talk, and I will promise we'll get to everybody's questions at the end.
Okay, great. Thank you so much. Good evening, everyone. It's great to be here with you all to kick off Breast Cancer Awareness Month. I see only one of our panelists has pink on today. So Melinda, you have it on. You have it on. So I'm here to take you through an overview of high-risk breast health care. I'm going to talk a little bit about risk assessment that was alluded to in the first presentation on breast imaging, and our approach to risk reduction strategies for those who do have high risk. My background is I'm a general internist, women's health provider, and preventive medicine physician. And so I'm a practicing clinician in our high risk breast practice. So, you know, what we've historically approached breast cancer screening is using age-based screening. And so many of us are familiar with recommendations for screening based on age alone. And we know now that age-based screening really ignores the very sort of broad range of risk factors that influence our individual risks for future cancer. And as we sort of have advances in cancer diagnosis and treatment, we are increasingly providing personalized care to patients based on their individual presentation. And so the age-based sort of screening ignores sort of where we are in our understanding of cancer. 2022 was the first year that one of the professional organizations called the National Comprehensive Cancer Center made the recommendations for the first time for individual risk assessment by age 25. And then the American College of Radiology, as we heard, followed suit, I think, the following year in 2023. So high-risk guidelines now exist from several professional organizations, and they promote the use of risk prediction models to estimate an individual's patient's risk. So we're going to talk a little bit about that. When we think about high-risk breast health care in general, I think about sort of 4 general areas. The first is identifying whether or not a patient is at high risk. High-risk assessment can be made through the identification of pathogenic variants through genetic testing. So we need to, in the process of identifying risk, ask ourselves if patients are eligible for genetic testing based on a threshold of potential risk based on family history. We also utilize, in the absence of a pathogenic variant, these risk prediction models, which really give a calculated estimate based on a comprehensive list of risk factors for an individual patient. But there's many nuances to this model, so I'm going to introduce you to a few of them. And then based on this information, we can provide risk reduction strategies to a patient based on what thresholds that they have in their personal risk. So we already heard in the previous presentation the definition of what is considered high risk. So a lifetime breast cancer risk greater than 20% is considered to be in the high risk range. So we're going to hear more about that. So how do we determine who is at high risk? In order to do that, we need to take a comprehensive review of an individual patient's risk factors, including inherited gene mutations. And so we're going to walk through that in a moment. But I just want to point out that while we place a large emphasis around genetic pathogenic variants or carrying the gene that puts you at risk for breast cancer, these pathogenic variants are responsible for a very small percentage of breast cancer cases. So the estimates are somewhere between 5 and 10% of these harmful variants. And many of us are familiar with the high-risk penetrance genes of the BRCA1 and the BRCA2 mutations. But the field of genetics is rapidly expanding and evolving, and we now know about many other pathologic variants. And so when we pursue genetic testing, we often do a sort of expanded panel looking at a number of different variants. The high-risk penetrance genes listed here confer a risk of a risk of lifetime risk as high as 60 to 80%. Whereas these moderate risk penetrance genes listed on this slide confer a risk more in the 20 to 30% range. So it helps us sort of categorize a patient's future risk. So as a clinician, one of the first things we do when we're caring for patients, whether this is in primary care or in a specialty practice, is we ask ourselves, is my patient eligible for genetic testing? And because this field is so rapidly evolving and the professional guidelines change rapidly in response to what we understand about genetics, we have tools in our electronic health record that support our providers in making decisions about who might be eligible. And I share this because I think it's important to know as a patient that this is a really complex field that not all providers are skilled at, and there are tools like this that support our providers. And you can see here that we have tools that have a tab for each disease, because the indications for testing differ based on the cancer disease. So from a breast cancer perspective, if you have a known mutation, there's no need to refer you to a genetic counseling or testing. But if you've had genetic testing, for example, greater than 10 years ago, you may benefit from repeat testing because of the advances in the extended panels. So this slide lists for you the professional organization recommendations around who should be tested or considered for testing for a pathogenic variant. And so I draw your attention to the underlying text that says personal history of breast cancer. And so if you have a diagnosis of breast cancer and meet any of the criteria on this list, you should receive genetic testing, ideally before you initiate any treatment, to inform your treatment decisions. So having breast cancer at a young age, under the age of 50, is a red flag for a potential pathogenic variant. So every woman under the age of 50 diagnosed with breast cancer should get tested. There are other indications of genetic variants, and that also includes the type of cancer that you have. So if you're diagnosed with a breast cancer that is what we call triple negative or hormone negative, then that is also an indication for testing. If you have a family history of a male breast cancer in your family, that's another indication. But even patients who have not been affected by cancer are eligible for testing if any of their family members who had breast cancer meet those criteria. So if a patient meets those criteria, their options in our health system are to go on and see a genetics counselor in our Smilow genetics clinic. Or we have tools now for our primary care physicians to do what we call point of care genetic testing in their practices, understanding that while we have over a dozen counselors, we can't always meet the demand of all the patients that get referred to us. So we have new tools to support our primary care providers to do point of care genetic testing, which is often a blood test. In the absence of a pathogenic mutation, or if a patient is not deemed eligible for genetic testing, clinicians rely upon these risk prediction models, and there are many of them out there. This slide provides a table of probably the top 5 most commonly utilized or most validated and usable tools that are out there. And so when we do these risk assessment models, they provide us with 2 numbers of interest that guide through the professional organizations recommendations for risk reduction strategies. We look at a lifetime risk and we look at a 5-year risk. And those thresholds, if you reach a lifetime risk greater than 20, you may be eligible for supplemental breast cancer screening with MRI or other modalities, as we just talked about. If you reach a risk threshold of greater than 1.67, you may also be eligible for risk reduction strategies using medications, what we call chemoprevention. There are several drugs that are available that can act as, that can reduce your future risk of a hormone-positive breast cancer. So here's a snapshot of one of the most commonly used tools that you too can go and calculate on your own. There's the sort of website where you can download this, risk prediction model. And this is the kind of output that you will get. What I'm trying to show you on the slide is several things. One is the type of information you need to be able to answer the questions to get an answer. And also showing you the results when you change the race of the patient from white to black. And you can see in the same patient who's 42, had their first menstrual period at 10, had their first baby at 35 years old, had 2 prior breast biopsies that were not cancer, had no atypia on those biopsy results, had 1 first-degree relative, so that's mother, daughter, or sister, in this case, 1 mom with breast cancer, And we calculate that risk for a Black woman. The results are on the left of this screen. So you can see this particular patient who's Black with those characteristics does not reach the 5-year risk threshold for chemo prevention based on this model, nor do they reach the high risk threshold for a lifetime risk greater than 20 for MRI. But if you change nothing but the race, this model actually suggests that this patient is eligible for both of those things. And some of this reflects the incidence rates of breast cancer between races, but it also demonstrates how imperfect the models are that we have that sometimes contribute to inequities in our ability to care for patients. And so I share this to also give sort of an abundance of caution that there are other models that don't take race into consideration that may be more appropriate. So the other model that is widely used and recommended by many professional organizations is something called the Tyrer-Cuzick model. In parentheses, I have the word IBIS there because that is the way that you can find it if you Google it if you go in and Google Tyrer-Cuzick, you're going to get a bunch of different options with web-based version that are really easy to use because they're pretty and they seem really easy to answer. But those are not validated. The only validated one is on this website that I list for you here. You actually have to download the software and it's a little cumbersome to use. And it's kind of easy to make mistakes and get the wrong answer. So when I talk about these risk models, I like to say it's sort of like garbage in, garbage out. If you don't put the right information in, you're going to get an answer that's not really reflective of your risk. So in this case, this model takes into consideration many more risk factors than the breast cancer prevention tool that I showed you first. It takes into account your height and your weight, whether or not you have an Ashkenazi Jewish ancestral background, what your breast density is. We just heard about how breast density is another additional risk factor that we need to take into consideration. It also takes into account family members outside your first-degree relatives and family members with ovarian cancer. It also allows you to say whether or not you or any of your family members who've been affected have had genetic testing. But you can make mistakes if you don't use the right age of the family members when you enter the information. It asks you for an age. If you give their current age and not the age of the diagnosis at the time of their diagnosis of cancer, or you don't include unaffected family members, you can overestimate risk or underestimate risk. And so it's really hard to use these models if you don't have experience utilizing them. So I'll share here with you the results of this model with that same patient, putting in some, average sort of age of first, average examples of like height and weight. And this is an example of what the printout might look like. And so you might remember the last slide, we had a range of lifetime risk between 16 and 20-something%. This one suggests the lifetime risk, if you look up in that right upper corner, is 26.5%. And the 5-year risk on the other was between 1.5 and 3, and this 5-year risk is 2.1. So it just demonstrates sort of, how imprecise these models are, even though they are the best that we have to give us guidance. I want to make a comment about polygenic risk scores, which are risk scores that you may get if you get genetic testing and provide, if you have genetic testing, they're looking at multiple of your genetic variants to try to estimate a score for you. And these often overestimate risk and make people really anxious that they get back during their genetic testing if they have no pathogenic variant and then they get this. I think we have to be really cautious that these scores actually are overestimate risk and are not really ready for prime time. So I just want to make one point about atypia. Atypia is a finding on breast biopsy that is another risk factor for future cancer that needs to be taken into consideration. So if you've had a biopsy, you want to know whether or not there was any atypia present. This is an additional risk factor that confers an intermediate risk. This is another tool that we utilize with our providers to help guide them on who should go on for surgery with atypia and or who might be eligible for risk reduction strategies. I want to highlight that because this is such a complicated area, we get referrals from primary care physicians and OBGYNs and self-referrals from patients to support them in helping them estimate their own risk and determine their eligibility for genetic testing. And if you were to come to see any of our providers across our network, this is the type of clinical care and counseling that we would provide. We don't have time to go into these all these different strategies, but we talk about prevention strategies and early detection strategies. And based on the individual risk and the patient preferences, we can talk and counsel about lifestyle and behavior that we're going to hear about from Dr. Irwin, chemo prevention or medications to reduce your risk reduction mastectomy for those with lifetime risk greater than 40%. And then their early detection options are not preventing cancer, but finding it early. And that includes self-exam, clinical exam, and the breast imaging that we just heard about from Dr. Lotfi. So I'm going to stop there because I know I took more time than I should have, and I'm going to pass it to my colleague, Dr. Irwin.
Okay, thank you. And I'm going to try to get it into the right mode. You could maybe answer a question while I'm doing this. Did I freeze?
You're good. I think we see
Okay.
presenter mode though. Or you're not full screen yet.
Okay,
gotta
good.
Switch your screen.
I was scared.
you
I
go.
thought I
Perfect.
froze. I thought I froze, but I'm good. I'm not frozen. All right. I was thinking maybe we can answer some of the questions in the chat while I'm presenting, just in case we don't get to all of the questions. Good evening, everyone. My name is Melinda Irwin. I'm a professor in the Yale School of Public Health and deputy director in the Yale Cancer Center, and I'm going to share with you breast cancer prevention. And I'm going to really focus on beyond individual risk factors and more how the environment and systems shape our risk for breast cancer. Also, I want to first start with acknowledging that breast cancer mortality rates have decreased by 44% since the peak in 1990. And much of this success in reduced mortality rates is because of what Dr. Lotfi said in our early detection and our ability to screen breast cancer, which results in an earlier stage at diagnosis. And then also amazing advancements in treating breast cancer. And so those together have really helped reduce breast cancer mortality rates. But what about preventing breast cancer outright so that we don't have to deal with treatment? So I know this is a busy slide, but it highlights many of the risk factors for breast cancer. And if you look sort of at the top going to the clockwise, in purple are the non-modifiable risk factors. And Dr. Battaglia mentioned germline mutations. And while those aren't sort of modifiable, there are ways that we can be aware from them and change our screening guidelines. And then the other non-modifiable are female sex, older age, certain race and ethnic groups have a higher risk of breast cancer, family history, breast density, previous history of breast cancer, and age at menarche or a first period, and then age at menopause. The green factors on sort of from the 6P at the bottom to the top of the circle are what we call modifiable factors. And these are primarily related to lifestyle behaviors. So our body composition or whether we're overweight or obese, physical activity, diet, and alcohol, as well as oral contraceptives and hormone replacement therapy in the postmenopausal years. So I'm going to focus on those for the remainder of the talk. Unfortunately, over the past 3 decades, we've seen a significant increase in the prevalence of obesity, not only in the US, but globally. In fact, every country across the globe has seen increased rates of obesity. Obesity is defined as a body mass index of 30 or greater, and body mass index is basically our weight adjusted for height. It's an imperfect measure because it does not take into consideration the amount of muscle you have versus adiposity. And we know muscle weighs more than body fat. But on a population level, it's a pretty good indicator. And what's concerning is seeing that back in the 70s, rates of obesity were in women 17%, and now they're up to 42%. And during the same time period, over the last 30 or 40 years, we've seen a significant reduction in physical activity levels. And much of this is because of technological advances. We can do our work from home, from a laptop, even from an iPhone. So this has created a society that is very sedentary. So it's not so much about doing exercise, but are we sitting too much and how to reduce our sitting time. I present these 2 slides to make the point that this is not something that's happening on an individual level, but on a societal and global level. And therefore, the interventions needed to reverse these trends in obesity and inactivity have to be at the environmental, societal, and policy level. And so discussing that, you may have heard the term obesogenic environment, and this is the fact that we have widespread availability and marketing of high calorie and processed foods. There is recent research showing that more than 50% of the foods people consume per day are highly ultra-processed foods. This is partly because that's what's available everywhere. It's ubiquitous, it's cheaper and it's easier, and access is everywhere. So we have limited access to affordable, healthy foods. We also have an urban design that favors cars over walking and biking, and work environments with long sedentary or sitting hours. And then lastly, in our free time, we're consumed with social media, which is leading to more sedentary behaviors. So what are the mechanisms of how some of these modifiable lifestyle factors related to body weight, physical inactivity, poor diet, and alcohol might increase risk for breast cancer? Well, we know that they're primarily through estrogen, inflammation, and metabolic markers such as insulin. Delving down a little bit deeper, we know in our postmenopausal years when women stop producing estrogen via their ovaries, they continue to produce it in their adipocytes, in their body fat. And this is from the conversion of androgens to estrogens via the enzyme aromatase. We know that this is really important because in women who have estrogen receptor positive breast cancers, they're prescribed as standard of care an aromatase inhibitor, which inhibits the conversion of androgens to estrogens. So this is really showing that estrogen is a primary mechanism that mediates certain modifiable and other factors related to breast cancer. So research on trying to reduce estrogen levels systemically, as well as reducing inflammation and insulin and other metabolic markers, is really important to better understand the right type of intervention for certain types of people. You've heard a lot recently about alcohol and how alcohol increases breast cancer risk. And the way this works is alcohol or ethanol can, when we drink it, it's more of a focus on, there's a dose response effect here. So one drink might be okay and not much of a risk, maybe a lifetime 5% higher risk, but it's if you have 2 or 3 or 4 in a day, that's where your risk of breast cancer really increases. And that's through how alcohol or ethanol is converted in the enzyme that of ADH that then leads to a chemical that can cause chromosome rearrangement and mistakes in our DNA. So prudent, want to be modest with our alcohol intake. So I want to go back to talking about the lifestyle, these factors in the environment. We know that lifestyle risk factors are shaped by the environments we live in, and that our lifestyle choices are strongly influenced by the environments, the policies, and systems. and that our environments often promote unhealthy eating and sedentary behavior, and that access to places to exercise, affordable healthy food, and supportive policies are key to prevention. And I want to dig deeper on the sort of reducing sedentary behavior and making sure you understand the importance of this. This figure here is based on hundreds of prospective cohort studies that have enrolled individuals, let's say at around age 40 or 30 or 20, and followed them to 50, 60, 70, 80 years of age and looked at mortality as the outcome, cancer mortality as well as cardiovascular mortality. And what's really important to recognize in this figure is this drop, that going from nothing, being very sedentary, to just doing something is where you see the most bang for your buck, the biggest reduction in breast cancer risk or mortality, implying that just doing something is better than nothing. It doesn't have to be training for a marathon. The goal, the recommended amount is 2.5 hours per week of moderate intensity, such as brisk walking. But it's really important that the research has shown that really just doing something can be beneficial. This same figure comes up time and again in studies looking at walking. And these are from pedometers, from iPhones, when you look at how much steps you've taken, or Fitbits, showing once again a similar curve, that going from very little walking, less than 1,000 steps per day, which is only a half a mile in all of our steps per day, not in kind of going for a walk, but from when you wake till you go to bed at night. So going from 1,000 and trying to increase it 1,000 steps per day or more has a significant reduction in risk for all-cause mortality as well as breast cancer mortality. 2,000 steps per day is equivalent to a mile. So if you can kind of think about increasing 500 or 1,000 steps per day throughout your day, then that's going to really help lower your risk. What about the dietary guidelines? There are a number of guidelines that are listed on the left here, but overall, what's recommended is a plant-based diet, where animal products are maybe 1/3 of what we eat in a day. We really want to focus on increasing our fruits and vegetables and our fiber, which is in our fruits and vegetables. We now have a really good food label, as you can see on the right, that tells you how much grams of fiber you get in various foods, as well as how much added sugar. That's new to the food labels, and that was a significant FDA policy change that came out just a couple of years ago, requiring that added sugars be pulled out on the food label, because it was very confusing to consumers. For example, if you're drinking orange juice and it shows a lot of sugars, but it might be that that's not added sugars to the orange juice. So more important to look at the amount of added sugars on the food label than the overall sugars. We want to maintain or increase our protein per day to about 1.2 grams per kilograms. Generally, most people eat plenty of protein in their diet, even though there seems to be a lot of advertising out there to get more protein, but most people eat plenty of protein. And in thinking about the type of protein you get, having it from fish and maybe poultry, and reducing it from processed meat, which in turn will also reduce your amount of sodium and low saturated fat. What about supplements? So the American Institute for Cancer Research, as well as the American Cancer Society and NCI, do recommend that you do not rely on supplements for cancer prevention, and to reduce your risk of cancer, to choose a balanced diet with a variety of foods. And those diagnosed with breast cancer or any cancer, it is critically important to share the supplements that you're taking with your provider, because they could interact with the treatments you're receiving and reduce the efficacy of the treatments. But guidelines are that you should not rely on supplements for cancer prevention. In fact, it's important to recognize the word supplement. If you are low in that level, it helps to supplement. But if many people are already getting enough vitamins and minerals from their diet, and having additional supplements on top of that is not any added benefit, and in fact, it could be harm. So I just wanted to quickly highlight where the research, some of the studies that we've done of diet and exercise and weight management interventions and the effect on breast cancer risk and outcomes. This was a trial we completed about 10 years ago now, and it was in postmenopausal women without breast cancer. But it was a 4-arm randomized trial of diet alone, of all the recommendations I just mentioned, exercise, which was basically brisk walking for 2 hours per week, and then the combination of diet and exercise. And really the takeaway here is all the negative signs you see in all of these markers, biomarkers related to breast cancer. So higher levels of these increase your risk of breast cancer, except for SHBG. The diet and exercise interventions, significant reductions in insulin, in CRP, a marker of chronic inflammation, and in our estrogens. And then the figure on the right shows estrone levels, which is the most common estrogen in postmenopausal women. And you can see just the significant reduction in estrone levels with diet, exercise, and the combination of about 10 to 15%. And this was within 3 months of a healthy eating and exercise program. We just completed a trial in women who were receiving chemotherapy for breast cancer. And what we were able to show in working with the registered dietitian on our team, those who were randomized to receiving counseling of healthy eating and exercise over the year from their diagnosis through chemotherapy and at 1 year, working with our dietitian, they were able to increase their physical activity levels and the diet quality, the quality of the foods they were eating during chemotherapy. And what is quite remarkable is that this intervention led to a 53% pathologic complete response rate compared to 28% in the usual care group. Both groups were receiving chemotherapy, but those that were randomized to the exercise and nutrition intervention had less breast cancer at surgery. So this was a group of women receiving neoadjuvant chemotherapy and then had surgery. And at the time of surgery, those in the intervention group, there was less evidence of breast cancer. What is the mechanism of that? Well, in this trial also with women with breast cancer, we showed that really this intervention led to favorable changes in body composition, but also a reduction in C-reactive protein, which is inflammation, insulin, and leptin. So I just want to touch upon anti-obesity medications because I know that this is a lot of patients and people with and without cancer are very interested in the role of these medications, which are remarkable, really profound in the amount of weight loss and adiposity loss that occurs with these medications, which are now sort of called GLP-1, glucagon-like protein 1 receptor agonists. There's really limited research on these anti-obesity medications and breast cancer risk or outcomes among those with breast cancer. It is being conducted now. It's evolving. So in 1 year and in 2-3 years, there'll be more research out there. But right now, there is very limited information about these medications in regards to breast cancer. We do know that the mechanism is they cause significant weight loss, up to about 20-25% loss, and metabolic changes, such as the ones I just mentioned, all these metabolic markers. Most of the studies that are done are observational, looking at outcomes, except for the trials of testing the medication on weight loss. But in regards to cancer, they're observational, and so there isn't a cause and effect relationship yet established. Most important, if you are considering one of these medications, discuss it with your provider, especially if you've been diagnosed with cancer. I always get this question. I think it's really important. Many people follow the diet and physical activity guidelines, and they can still develop breast cancer, and it's very frustrating. So it's important to note that a healthy lifestyle lowers risk, but does not eliminate it. Whether you like this analogy or not, I think it's simple and can be helpful. It's like wearing a seatbelt, which lowers your chance of a severe injury in a car crash, but it does not guarantee safety, but it lowers your risk, much like screening and leads to earlier detection and practicing changing some of the modifiable risk factors, it lowers your risk. But most importantly, breast cancer is influenced by a mix of factors that are genetic, reproductive history, hormones, environment, and chance. And that for women already diagnosed, these modifiable factors might also improve treatment tolerance, reduce recurrence risk, and improve outcomes. So even if you've been practicing these healthy behaviors and you're still diagnosed with breast cancer, maintaining a healthy diet and exercise can help with your prognosis. Okay, I think my last slide here, I just want to touch upon postmenopausal hormone replacement therapy because there's been a lot of information on this, especially on social media, and it can get very confusing to individuals. HRT, as you might know, replaces estrogen and progesterone hormones that decline during menopause. And HRT reduces menopausal symptoms and also protects against osteoporosis. Breast cancer risk increases with longer use of HRT. Recent research that came out in the last couple of years showed that the risk was less in women from age 50 to 59 than in women 60 or older. So many women might take HRT in their 50s and then stop it when the menopausal symptoms subside. And research recently has shown that that's a lower risk. It's also really important to note that hormone therapy, which is also called endocrine therapy for breast cancer, should not be confused with HRT. HRT and endocrine therapy produce opposite effects. Endocrine therapy for breast cancer is a medication to lower hormone levels systemically, like aromatase inhibitors, or block the action of the hormone at the receptor, such as tamoxifen, which in turn lowers risk of breast cancer recurrence and also can be used in women at high risk for breast cancer. Most important is to discuss the potential benefits and risks of HRT with a healthcare provider before starting treatment. So in closing, I just want to kind of remind again that 30% of breast cancers could be prevented through lifestyle changes, yet lifestyle is driven by the world around us, the food industry, urban design, and social norms. We know that changing habits, especially in a world full of stress and limited access to healthy foods and environments that don't encourage physical activity, is not easy. So, hoping that there'll be policies and systems changes that can make the healthy choice the easy choice. And important to note that progress is uneven across populations and that access to care, socioeconomic status, and environmental exposures contribute to disparities. And unfortunately, there are disparities in breast cancer incidence and mortality. And so lastly, every step we take toward healthier habits matters. Small changes add up, such as just focusing on reducing sedentary behavior. And that combined with community level efforts will reduce breast cancer risk and improve overall health. So with that, I will stop sharing.
That is great. Thank you, Dr. Irwin. We do have a few questions that have been submitted, and couple of the two that we've answered a few of them directly, but a couple that are out there, radiology questions. So Dr. Lotfi can take the first one, and maybe I'll take the second one. So a questioner asks, and she's a breast cancer survivor more than 2 decades ago. And she says, yes, if mammogram and ultrasound are done and compared to past results and found to be a change, what is the next step? So if there's a change on your mammogram and your ultrasound, what do you do next? And you're muted, Parisa.
There we go. Sorry about that. If a patient is found to have a mammographic or sonographic abnormality without any other symptoms, that is called a callback from screening. Generally, women are asked to return for additional specific dedicated diagnostic imaging, which means additional mammographic views, targeted ultrasound with generally presence of the radiologist who can assess. And then the radiologist can determine if there is a need to perform a needle biopsy, follow up, or do nothing.
Yep. So yeah. So that's a great answer. I hope that answers your question. you'll get called back and we'll do additional workup with other images. So the other radiology question is, what is molecular breast imaging? And so molecular breast imaging is a nuclear medicine study. So there's a radioactive substance called technetium, and in a form of it is used very commonly in different medical tests, especially a test of the heart. And what they found when they were testing people's hearts is that breast cancers would light up in this test. So the substance that they were giving to look at the heart would go to breast cancers. So they realized they could turn this into an imaging test, and it's an imaging test that has good sensitivity. It finds cancers at a similar level to MRI and contrast mammography. It hasn't been studied as much. It has some downsides though, as opposed to a contrast mammogram, which takes about 5 minutes, or an MRI, which takes about 10 to 20 minutes. Every image on a molecular breast imaging is about 50 minutes, 50. It has gone down with better equipment, but it's a longer scan, and it doesn't quite give the anatomy. It doesn't show us the anatomy like MRI or contrast mammography does. So it hasn't been as widely accepted. But it's a test. Basically, you get injected with a radioactive substance, and then you get imaged. So we are. There's no more questions on the chat. We can stay for another 5 minutes, or if one of our panelists would like to add something, I'd be happy to listen, or I can ask questions. People. Actually, one of our listeners had a question about the risk models. And so Tracy, yes. So, and don't forget to unmute. You mentioned 2 websites, one of which, one of which is web-based, and the other one you had to download software. Can anybody download that software, or do you have to get permission?
Yeah, it's free. It's free. It's free. It's just the interface is not very intuitive. It's kind of complicated. It's not clear exactly what they're asking. So I think it's easy to make mistakes using that model. There are other versions of it on the web that are like a pretty interface and clear questions, but I don't think that they're validated. And so I wouldn't necessarily encourage using them. So, I mean, I think you could go ahead and assess your own risk and print out your results and bring it to your provider. Anytime I see a patient and they bring me a risk model result without the information of what went into it, I just repeat it because I don't know what went into that calculation to give the result. So I think the message I would give is these are not easy to interpret, and don't panic if you get a very high risk. You should review it with a provider who has experience using the models.
Yeah, so as someone who's used the models, I would definitely concur. There are little things that can make a big difference. Height and weight are one. You have to put those in to be accurate. And if you're tall, it increases your risk of breast cancer, which is not intuitive, but it's in the model. One thing that seems to drive it for a lot of our patients is having a first child after 30, which has become extremely common. Mm-hmm. And so, yeah, then would you like to comment on that, Dr. Battaglia?
Yeah, I mean, I think, we take a lot of the reproductive history into account for breast cancer risk. And the way that I like to think about it is it's really just to sort of the amount of time an individual has exposure to estrogen unopposed. And so when you have your period very early and you don't go through menopause until very late, and you don't have a child at all or have a child at an older age, you're not opposing any of the natural hormones of sort of your normal cycles that interfere that may be contributing to breast cancer risk. So having children younger for whatever reason, having any children is protective. Having children at a younger age probably has something to do with the breast development and the opposition of the hormones.
Great. And Yeah, I have no other questions to ask. Oh, and Dr. Lotfi's typing an answer, looks like, to one last question. Anything else anybody would like to add?
I'll just
Let me
say
ask one last
if
question.
anyone's still on and does have questions, feel free to email me directly at melinda.irwin@yale.edu. I'm happy to answer questions later on as well.
And I have one question, Dr. Irwin. So exercise, we know, and being thinner reduces your risk of postmenopausal breast cancer. Does the same thing apply to premenopausal breast cancer?
So for exercise, yes, it lowers your risk from, if you exercise childhood, premenopausal years, later on is a significant lower risk for developing breast cancer. The research with obesity is a little confusing because it's related to estrogen and whether you have a 28-day cycle. And so sometimes if you have high amounts of body fat, you might not have a menstrual cycle that's every 28 days. And so it kind of confounds the relationship with breast cancer risk. However, with that said, we know that weight gain from adolescence through adulthood, independent of your BMI, is associated with increased breast cancer risk. So I think two messages I always like to tell people is to try to prevent weight gain and to try to reduce sedentary behaviors.
All right. Well, I'd like to thank our panelists again and let everyone know that we have 2 more of these webinars. The next one is October 9th, and it's entitled Early Stage Breast Cancer, What Patients and Families Should Know. And the one after that is October 16th. So these are all on Thursday nights. And October 16th is Progress in Metastatic Breast Cancer Research and Treatment. Talk about the ways we have improved the treatment of metastatic breast cancer. It's been quite astonishing over the past decade what has the advances we've had. So that is all. Looks like we're good. Okay. Thanks everyone. And Eliza, unless you have any other things, we will say goodbye.